As Cecile mentioned, I'm the team lead for RPIW number 20, and we will be reporting to a tap time of 20 minutes in accordance with this standard work combination sheet. So this is our great team. You know, it's we call ourselves the formidable forerunners. And without a great team, you know, with a great team, even befuddled and confused team leaders like me can actually do good work. So on your left, you see our sub-team leads, Stacey Smith-Coleman, the lean leader in training, Jerry Cruz, Barb Pastra from the West Hill Clinic in MOA, and again, a very, very valuable person to make that connection to the clinic. We have Ken Weiss, the patient representative, Amanda DeGrand, an ED nurse, a very veteran and helpful KPO, Donna Cook, and Dr. Corny Smith is both an ED physician and a rural community physician, and also myself. So this is our project form, and our overall target statement was to reduce the lead time for referring patients by 50%. I just want to say a couple of things about how helpful our sponsor, our process owner, and our JBA consultant were to us. They are respectively Dr. Hurkinson, Dr. Gallins, and Richard Abercrombie. Again, we just felt we had great support and gave us a lot of thought and a lot of background to how we could make a difference. The current situation that we found was that oftentimes the community clinicians don't have the information, or they don't reference or can't reference the PACS, the Picture Archiving System, or the SLUR, the Saskatchewan Laboratory Results Repository. Sometimes patients come in who are referred, they'll come with a form, or quite often, even when they come with a form, it won't have a differential diagnosis, it won't have orders, it won't have something with respect to disposition of the patient or background. And so, again, this is what we were starting with. So, I'll turn it over to you.
So our pre-RPIW value stream map just really outlines the process that our patient followed in the current state, or the before Kaizen patients being referred into the emergency department from the community. So those patients were experiencing a total lead time of 2 hours, 15 minutes, and 29 seconds. So that represented about 80% non-value added time. So the majority of that was actually wait. During our data collection week prior to our event, we found an average of about 76 patients per day coming into the emergency department. Referrals represented about 8 of those patients. So 10% of emergency department visits were actually referrals in. So the following bar graph just shows the number of referred patients compared to the total number of emergency department patients. So what we can see really is that there's some variation based on the day of the week. The blue part of the bar is non-referred emergency patients, and the red part at the bottom is referred emergency department patients. So you can see we have peaks on Fridays and Mondays, which is no surprise to the staff of the emergency department. We have a visual of the defect on that emergency department referral form. And so John and I and Dr. Hickinson during our data collection period just reviewed those referral forms for the 5 essential elements that the emergency department tells us are required. And when those elements are missing, it causes rework for them and as well as delay for our patients. So our target progress report and results sheet outlines the measures that Don and I and Dr. Higginson found in our preparatory weeks. You will now hear the team describe how changes that we've made this week will have affected those final measurements. Takt time calculation for the purpose of this project, 17 minutes, 47 seconds. So what this time represents is the demand on the emergency department per day. 17 minutes, 47 seconds is the time interval at which a patient needs to leave the department with treatment complete to keep patients flowing. Having said that, we know the emergency department takt time is variable based on somewhat unpredictable demand.
I'll start with the idea summaries first. Here we have 3 examples explaining some of our concerns and problems with the current referral form and process which prolongs a patient's visit. Typically we had a problem with the old form with misinformation, inadequate information or very minimal information. For example, first one, we see patients arrive at registration with no indication where to go and then often being sent to triage to be sorted out. Often this creates a bottleneck and increased wait times for the patients. Second example, often we see confusing orders or requests for multiple interventions and nursing orders causing unnecessary confusion and frustration for the nurse and the patient, leading to unnecessary waiting times. Last example, often we see a patient refer directly to the ED physician with poor communication and with little or no history or a plan at all, causing a significant delay in the process. We move to the spaghetti diagram. The pre-Kaizen spaghetti diagram indicates an average walking distance for the ED physician of about 276 feet. This includes a walk from the workstation to the patient and then returning and finishing your charting and then eventually returning back to the patient after all investigations have been completed to finalize a diagnosis and disposition plan. Post-Kaizen indicated about a 50% decrease in walking distance of about 138 feet. This was obtainable with a properly used and completed new referral form. In most cases we could receive all investigations beforehand and with good communication from the referring physician, go to the patient once with a diagnosis and a disposition plan. With regards to the new form development, our pre-Kaizen form had a few deficiencies and during the week we went through about 5 revisions and came up with a concise and easy to understand and easy to complete referral form. We called it the Prince Albert Parkland Health Region Hospital Orders and Consultation Form for Primary Care Providers to include physicians and nurse practitioners. The form consists only of 3 steps, kind of making it inviting to complete. It indicates where patients have to go, the necessary instructions or orders for the triage nurse if not referred to another physician in the ED, and lastly the consultation information with proper history and diagnosis for a physician to a physician referral. We included Shelbrook on here as they would be our main peripheral site for simple orders. The form includes a few visual cues in bold and different sized fonts to facilitate the completion. We'll move to multiple skill training. We went out to all the Prince Albert medical clinics except for those in the periphery such as Big River, Spiritwood, Shelbrook and Birch Hills, and we introduced and explained the new referral form's purpose and process. We mostly met with various office managers, but did have the opportunity to speak to a few physicians and a nurse practitioner. The peripheral clinics were telephonically contacted to relay the information. Our message was to give the new form a good trial by completing it manually first prior to EMR implementation and then to receive feedback in the process. With regards to work standard, we finally developed a work standard to explain the steps for completing the form for our primary care providers, and this clearly explains the 3 main steps. The form is to be used by community physicians and nurse practitioners to refer patients to the Victoria Hospital to have treatment or investigations completed under their care, or for a consultation with an emergency department physician or specialist. The work standard emphasizes the importance of location, diagnosis, and order disposition, as well as consultation. It also emphasizes the need for accurate completion. I don't think my mic was working, but I'm speaking loud enough.
Hi, I'm Barb. And I know from my experience working at a clinic that patients are not always sure what to do when they're leaving the clinic and where to go when they go to the emergency department. Sometimes they're under the assumption that because their doctor is called ahead that they actually have an appointment and they don't have to go through admitting, and they don't know that they have to go through admitting or to triage, then they have to sit and wait. So we developed a standard patient instruction sheet to attach to the hospital order and consultation form, so the patients would have a better idea of what they need to do when they go up to the hospital. Then we developed a work standard, so clinics would know how to use the instruction sheet. And in the end, our plan is to track who we've spoken to about these new forms to make sure they know how to complete them or to
Hi, my name is Amanda. So, a part of the process, we implemented a standard worksheet for an IV tray to be located at triage. A problematic area we have observed was the lack of supplies located near the triage area, as it is a part of the role as a triage nurse seen right now is for IV insertions for those people who are being referred from the clinic for IV therapy. Another problem observed was improper disposal of used needles following IV insertions, as the treatment area was not properly set up. There was no sharp container near the area, the nurse having to walk approximately 10 feet with a used needle. So before the implementation process of the supply tray, the calculated travel time was approximately 72 feet. I'll get you to go to the IV tray. Here's a picture showing the new IV supply tray that was implemented. You see it's in an appropriate location, it's clearly labeled, fully stocked for the triage nurse's accessibility. There is also a sharps container included in the tray, as you can see there, for proper disposal following IV insertions. I'll get you the next, the previous story. Yeah. So with the implementation of the IV tray, the travel time has been reduced to approximately 25 feet, decreasing the cycle time to 4 minutes and 46 seconds from 11 minutes and 38 seconds. As a result, we have eliminated this cycle time for IV setup as well as the defect by adding a sharps container. Next slide. A standard worksheet has been completed and located above the tray, which has been explained, understood, and demonstrated to our ER porter, which the role has been delegated to. It is also the role to keep a log dated and signed when the tasks are completed. So here's just part of the log as well. So another task that was completed by our team was the implementation of the 5S area in the ER department near the nursing station. I'll get you to this is a picture of pre-Kaizen 5S area. You see there's lots of clutter, items on the floor, there's snacks and drinks in the area there where on a daily basis the drinks spill onto the charts, which is problematic. As well as the binders, there's old information. I'll go to the next one. So, where am I? Sorry. So as you can see, our pre-Kaizen score following this we had an evaluation of 1.1 out of 5. We'll give you the post-Kaizen picture. You see it's clearly labeled. The snacks and drinks are gone. We have a sign displaying that there is nothing to be in that area. Binders were removed and clearly labeled. The next slide. So our this is another post-Kaizen picture. Our post-Kaizen evaluation score is 2.5, which is a 35% improvement.
Hi, my name is Jerry.
Just speak loud.
So, anyways, I will briefly summarize the tools that we use during the pre and post-Kaizen and the RPIW event. These are the tools we use to gather information and observation and data collections. This is the first one. This is a pre-Kaizen, and this is time observation form, and it shows the beginning of and the end of the process, and it shows the time for one cycle. On the post, it shows again the same form, but it's this after, and it shows the difference in time. The next form or tool that we use is called the standard work combination, and this one it shows the total time, the whole process, including the wait time. This is again the pre-Kaizen. And then the post shows we eliminated a few of the steps. I think there are 2 or 3 steps that we eliminated from that process, and it decreased the amount of total time, and also decreased the wait time. The next one shows the pre. This is another tool that we use. This is percent load chart, and it involved the operator. In this case, they had the triage nurse and the physician in ER, and it take note of 2 steps in the pre for the ER doctor, and on the post, this is the post percent load chart, and it shows there's only 1 step. We eliminate 1 step in the doctor's part of the process. So on the post value stream map, this from, if you remember what Stacy said, these are like from the pre. We managed to change the process and decrease the time to 1 hour 34 minutes and 30 seconds. And I just want to emphasize that we increased the value added to 88.6 and decreased the non-value added to 11.4. So basically, we flipped the numbers from pre to post. And we also eliminated some of the starters, some of the errors or problems in that whole stream.
Thank you, Jerry. So we now have our newspaper. We do still have several items on the newspaper, despite the team being very successful, I think, this week and working very hard. Just want to highlight a couple of them that we're going to follow through to ensure the success of this program. And so next week, Dr. Hookinson, Stacy, and myself, Dr. Gallins, have an appointment at the Regional Medical Association to follow up with those the physicians in terms of, obviously, as Dr. Smith mentioned, we met with a lot of office managers, a few physicians, but we want to make sure that everybody is aware of the new form and the new process. The second thing that we're going to do by way of follow-up is to insert this new form and new process in the physician's EMR, electronic medical records. That's either a Curo or MedAccess. And so those things that we think will actually help to solidify the game. Next. So this is our final target progress report result sheet. I'm not going to go through each and every one of these. I just want to say that I think that because we were able to concentrate on the referred inpatients, we were able to make some good progress. on every one of the measures. One of the measures I will highlight, though, was in terms of the defect rate. We had counted defect rate in ones where missing information by way of orders or the history and physical and the disposition of the patient and so on. We were able to reduce from a 25.4% defect rate to a 15% defect rate. So again, still more work to do, but it does make a significant difference.
Good afternoon. My name is Ken. I'm the patient member of the team. The pre-Kaizen waste wheel, all of the post-its that you see on that board are ideas and observations of our tour of the emergency department. And after consideration, next slide please, you'll see a number of them have X's on them. All of those were investigated and taken care of one way or another. The ones that do not have an X are items that cannot be handled in this RPIW, but could be handled in another RPIW or resolved in a different avenue. As you've gathered from the previous slides and presentations, you know that we have impacted pretty well all of the areas and the goals that we set for ourselves. All targets will require some fine-tuning and more refinement in the sense that when you stop and think about it, that is the essence of the lean process, continuous improvement. The workshop summary, understanding the process, team members have been motivating each other actually and encouraging each other, and then teamwork, communication and respecting was all part of our process throughout the week. Thank yous. We have quite a few thank yous to do on behalf of the formidable form runners. Our sponsor, Dr. Hookinson, team lead, John Piggott, our sub-team lead, Stacy Smith-Coleman, and our process owner, Dr. Gallons. We'd like to extend a thanks too to all personnel in the emergency, admitting, diagnostic, imaging departments, and our consultant, Richard Abercrombie. And indeed, all the hospital and all the clinics that we visited, the staff who contributed their ideas and their expertise. Whenever we asked for something, somebody came up with something for us. And if they didn't have it, they went and got it. My personal thanks for the opportunity to be part of this team as a patient. And in particular, Barb and I would like to thank the team for their patience in explaining the process to us and the full acceptance as team members. Thank you.